The award is presented to a blood service or centre from a developing country that has made a significant contribution in strengthening transfusion practice within the country. It enables blood services or centres to attend an international congress of the ISBT and to organise an educational symposium. This year's award is given to the Lifeblood Centre from Gujarat, India.
We thank ISBT for recognizing our significant contribution in blood transfusion and your remarkable work to improve the safety of blood transfusion worldwide. Thank you.
We thank from the bottom of our heart to all the officials of ISBT for presenting us the most prestigious Developing Country Award 2020.
First of all, thank IMA Rajkot and Life Blood Center for this invitation, and I'm very happy to be in August present. So I'll start with my session on patient blood management on anemia and hemostasis. Yeah, this is forward now. This is fine. Okay. Okay, so we know that blood and blood products have allowed a lot of complex surgical procedures and has saved many lives. But we must also realize that blood transfusion is never 100% safe. So can we do something within our capacity, especially using blood sparing strategies, so that it can be made more safe? For example, autologous blood transfusion, we know that it exists, but it is not widely practiced. Intraoperative normovolumic hemodilution, that is, you take 2 units of packed cells from the person undergoing surgery, and then you can put saline, and then maybe if the patient requires blood post-surgery, you can use the same blood to transfuse. Not widely practiced. Cell-saving devices like cell salvage, intraoperative salvage, not widely practiced. We can also use drugs which can reduce bleeding or intraoperative hemorrhage. For example, we can increase the blood thickness by using recombinant human erythropoietin, not widely practiced. Use of antifibrinolytics, yes, some of the cardiothoracic surgeons do use it, but also not widely practiced. And then, of course, the use of recombinant factor 7A, off-label use, not widely practiced, mainly because it is expensive. So I'll give you a scenario here. A senior faculty of CMC is getting screened to donate blood, So we go and ask why you're screening. He said donating for wife because hemoglobin is 6.5 and tells directed donation. We told him that we'll definitely get a good blood to your wife, but not your blood. Because the chance of his wife carrying antibodies to his leukocytes are quite high, because she had she had children, and obviously she is likely to have antibodies to his white cell. So there's a chance of transfusion related acute lung injury. It usually happens when you transfuse more than 50 ml, any blood products where there's more than 50 ml of plasma in the system, like for example FFP or single platelet donations. They generally have more than 50 ml plasma. 1 in 50 transfusions which have more than 50 ml of plasma can cause TRALI. In fact, this is the most common side effect of transfusion, or adverse effect of transfusion reported in United States of America, even causing death. So you can see the X-ray changes. What happens is, moment this complication happens, you can see the patient who's lying down. It can happen within 6 hours of the transfusion of any blood products which has got more than 60 ml of plasma. A patient who's lying down, moment this complication comes in, you can see the patient sits up. It's worse than orthopnea. Patient sits up and is short of breath. You take the saturation, and saturation would have dropped less than 90. Of course, management, looking at the chest X-ray, you would want to give diuretics. No, diuretics doesn't help. Steroids doesn't help. It is basically helping the airway management. Sometimes you may require positive ventilation, you may require intubation, and sometimes ICU admission. Then of course, relative transfusion can also cause a complication called transfusion-associated graft versus host disease. Compared to bone marrow transplant, where it is desirable to have graft versus host disease because you want to get rid of leukemia, like graft versus leukemia effect, the graft versus host disease in transfusion has very adverse outcome. I have not seen anybody who has recovered from transfusion-associated graft versus host disease. They all die. So these are something that we need to educate somebody who's wanting directed donation. So safe blood has got 4 pillars. WHO has described this. Well-organized blood transfusion coordinated services in our country. Blood collected from regular, voluntary, non-remunerated blood donors, which of course Dr. Erika Wood also did emphasize, but from low-risk population. So what is low-risk population? That is the job of the blood bank to identify whether the donor is potentially coming from a low-risk population. So therefore, the questionnaires have to be really, really built, because it is basically getting information to see whether this person belongs to a low-risk population. And testing. You test for blood group, you test for compatibility, you test for infections, and you test for indications for which blood is being given. And the last, which is not the best practice in our country, is appropriate clinical use of blood and blood products. So when you talk about anemia, red cell units, we have got 3 types of red cell transfusion. We have got whole blood, we have got packed cells, and then we have got packed cells with additive solution. Whole blood, of course, less and less being used because it's got extra plasma. Packed cells are preferred, but it's like, almost 70 to 80% hematocrit. But the problem is, when you transfuse it, it's quite sluggish, so it doesn't flow very fast. So there is, anesthetists don't like this because they want everything to flow fast. Packed cells with additive solution is good because the shelf life of the packed cell increases. So what is a transfusion trigger? I think the word today used was not transfusion trigger. What is the, I think I forgot what Dr. Erika Wood said, but I generally call it as what is the transfusion trigger to tell that this person requires red cells. Bleeding, of course, is definitely one indicator, like trauma or very massive hemorrhage. But the classical is symptomatic deficiency of oxygen carrying capacity. Only that. It is not hemoglobin. I mean, we saw certain hemoglobins 27, less than 8. It is not hemoglobin. Because there are people with chronic anemia, aplastic anemia. They are very happy with a hemoglobin of 5. And you can see them run up the stairs. They will not be having any shortness of breath. They don't require time. In fact, they are so educated that they will say, no, my hemoglobin is 5, I'm happy with 5, I don't transfuse my blood. So therefore, it's not based on hemoglobin. Of course, sometimes you need to use hemoglobin as that big circle that you had, red becoming pinker and white. Patients who are in ICU, if they drop in oxygen saturation. So they may require, because there is a decrease in oxygen carrying capacity. So please make sure that the patient at least undergoes a trial of intubation before you can decide on increasing oxygen carrying capacity through transfusion. Compromised myocardial state, it is known that they should maintain a hematocrit of more than 32. And all those people who are undergoing chemotherapy, because their marrow is not going to compensate for the decrease in blood cells, for them you can use a cutoff. Some people, like I think in Europe and US it is 8, but in India in CMC we use 7. So please ensure your safety by documenting the symptoms of decreased oxygen carrying capacity or oxygen saturation. So once you have decided that this person definitely requires PAC cells or red cells, please make sure that you maximize the benefit to the patient. So, many of the physicians, pediatricians will call and say 1 unit of PAC cells. 1 unit of PAC cells may increase the hemoglobin, but there's a chance that it may only increase by 0.7 grams per deciliter. If you are lucky, it can go up to 1.5, but that is your luck. So whenever you have decided to transfuse PAC cells for decreased oxygen carrying capacity or anemia, please make sure you order 2 units of PAC cells. So, because you can't predict how much your hemoglobin is going to. Always ask for 2 units and not for a single unit. So, mother of a senior faculty has been advised by orthopedic surgeon to have 2 units of PAC blood post total hip replacement, as the hemoglobin dropped by 3 grams per deciliter. Yes, we know that there will be, it's a surgery which is involved with a lot of blood loss. So she was probably feeling a bit weak, and so as soon as I got the request, I said, I called. So I said, can we avoid the transfusion? Is she very is she breathless? Does she have history of ischemic heart disease? Mother of your friend. So the friend is so angry. What is bothering you? She's weak. Give her blood. So I said, okay, fine. And I said, can I start with 1 unit of PAC cell and then we'll decide? Because she's not that symptomatic. She's only feeling weak. So fortunately, I went to the blood bank. I said, who was a donor who had a hemoglobin of more than 15? Get me that PAC cell. And I gave her PAC cell, not even PAC cells with additive solution. Fortunately, after that, her hemoglobin went up by 1.5. She looked more cheerful. So I think my friend said, okay, fine, we'll stop with 1 unit of PAC cell. So sometimes when you are able to closely monitor, you can do this. But if you're not going to closely monitor, always ask for 2 units of PAC cells. Okay, this is a scenario that happened very recently. One of my obstetrician gynecologist, very senior gynecologist, she had malignancy, and post chemo her hemoglobin dropped 5.4. Her husband, who's our medical superintendent, he called me and said, Sukesh, we are coming to hospital. Can you keep 2 PAC cells ready for her? So he gave me her hospital number. So when I looked at the results, her hemoglobin was 5.4, MCV was low, and she was anyway put on 9 because she had some blood loss. So we know that there is most likely iron deficiency anemia, and we always have learned that anemia is iron deficiency anemia is the most common hematological condition in the world. It can also be presenting as a latent iron deficiency anemia, or a patient may be recovering. Biochemical parameters can reflect iron deficiency, and there's a gold standard like free erythrocytic protoporphyrin, which is not done anywhere in our country. That's a gold standard for iron deficient anemia. But one of the better ways of identifying iron deficiency anemia is to look at the peripheral smear, because we have been taught that microcytic hypochromic blood picture with anisocytosis diagnosis iron deficiency anemia. So thing is, when you look at this picture that you have there, now we are looking for microcytosis. Now size is always subjective. Suppose I show the smear to somebody, one day they will call it as microcytic, next day they may call it as normocytic. So size is always subjective. But what is very classically seen in this picture, or more objective, is the color of the red cell. Hypochromia is very classical. And there is something more that I can identify to you. Anisochromia. All the red cells are differently colored. Anisochromia is the best indicator of iron deficient red cells. So this is something I learned from cell counters. Nobody taught me. Nobody taught me anisochromia. Has everybody, we are all so many pathologists here. Have you ever heard of anisochromia? No. But anisochromia is so beautiful here, isn't it? So is there something like cell counter? I told you cell counter taught me this. I'm also shaking with this, So, fine. So this is an application of anisochromia in nephrology practice that I do regularly. So I'll take it with an anecdotal experience. 72-year-old gentleman, chronic renal failure on hemodialysis. His hemoglobin, his history of his ischemic heart disease, his hemoglobin drops to 6.5. He gets orthopnea. So to find out the cause for the anemia, the nephrologist said, we'll do bone marrow examination. So he got a little frightened, contacted us. He thought bone marrow examination is a huge procedure. His ferritin was 521, so they were planning for a bone marrow. So we told, just send your peripheral smear. Make a smear and send it by courier, and we will look at the peripheral smear. So when I get a peripheral smear from a patient in nephrology, I look at, the first thing that I look at, whether they're adequate reticulocyte. Because renal failure, erythropoietin is an issue. So now if I look at this blood picture, I can see there are 3 reticulocytes, all which we call as polychromatophilic red cells. So reticulocytes look like polychromatophilic, slightly blue red cells. Now I can see 3 reticulocytes here, so I can say, yes, there is adequate reticulocytes. Maybe he's on erythropoietin, so I don't have to worry about the erythropoietin part. But what is catchy here is the anisochromia. Some red cells are hypochromic, some red cells are normochromic. Now we know that red cells are in the body for 90 to 120 days. Now we want to know whether the hypochromic red cells happened recently, then it's a bad story. If hypochromic red cells happened 120 days back and normochromic red cells happened recently, good story. Now how do I identify that? Look at the reticulocytes. Reticulocytes have only 2 days life. They will tell you what is happening recently in the marrow. Now if you look at the reticulocytes, the polychromatophilic red cells, the bluish color red cells. One of them is normochromic, one of them is hypochromic. So this anisochromia is happening every day. His marrow is not able to give iron equally to all the red cells, which happens in anemia of chronic disease or anemia of chronic renal failure. So what is the report? No need for erythropoietin, but this guy will require iron. Even if the ferritin is 521, he will require iron. Of course, he was given a unit or 2 units of packed cells. And during dialysis, he was given iron infusion, along with the dialysis system. In 1 week, his hemoglobin, 2 weeks later, his hemoglobin was 11.2. But of course, 2 units of packed cells were also given. But from 6.5, 11.2, you must realize iron is magical. If a patient has iron deficiency, you give iron, it's magical. The hemoglobin comes beautifully. Now, when I get a peripheral smear of a nephrology patients here, I can say that, okay, no need for erythropoietin, but please give iron because there are hypochromic red cells. When I look at this, I will say there is no polychromasia, so you need to give, and also there is hypochromia, so you need to give iron to this patient, but you also need to give erythropoietin. If the patient is not on erythropoietin, give erythropoietin, but if it's already on erythropoietin, increase the dose of erythropoietin. So, very simple blood picture approach to management of iron deficient erythropoiesis. So coming back to my patient, so many of these things I started learning because I started using cell counters, and there is a particular parameter, like for example, anisochromia. There is a cell counter which will give you hemoglobin distribution width, not only red cell distribution width, it gives you hemoglobin distribution width. So it actually is describing anisochromia. Then it also gives you information on what is the hemoglobin content in the reticulocyte, because it anyway identifies reticulocyte because there is reticulin, but it also tells you what is the hemoglobin content of the reticulocyte, whether it's adequate or not adequate. So this is called as CHR, reticulocyte hemoglobin content. Some of the cell counter call it as RET-HE, that is reticulocyte hemoglobin content. But please remember, when you see those reticulocytes which are hypochromic, it is the earliest indicator of iron deficient erythropoiesis, as good as free erythrocytic protoporphyrin or zinc protoporphyrin. So many of them are calculated, but some of them are measured, but they are available in most of the cell counters nowadays. So you can use this parameter. So when you look at these parameters, percentage hypo or HDW is anisochromia, helps diagnose iron deficient erythropoiesis. Reticulocyte hemoglobin content will tell you the hemoglobin of the reticulocyte, and it's probably the earliest indicator of iron deficient erythropoiesis. And when the patient starts iron, the shift of HDW will tell you, and it shifts very fast. Within a day it will shift. It will tell you response to treatment. So you can actually catch hold of non-compliance One of the biggest problems with the treatment of iron deficiency is non-compliance. So we can catch all the non-compliant fellows. And all this was taught by a cell counter. Now coming back to my colleague. So she's on the way from hospital, she's getting into the car, and I had a chance to look at her blood film. She's on iron. So when I look at her blood film, she has got increase in reticulocyte. There are hypochromic red cells because 120 days back, these cells are iron deficient. But there are normochromic red cells also. But the new reticulocytes were well hemoglobinized. That means she's responding very well to iron. Very well hemoglobinized. So when I looked at that, okay, we know that CHR, the reference range is 33 to 35. I am not able to say from looking at the blood picture whether it is 33, because 33 will also look well hemoglobinized, whether it is 35, 35 will also look well hemoglobinized. So if I had the capacity to say that this is 35, then I'll say, do you really want to come for transfusion? So responding well to iron, red. So then I started going to look at the red HE, because the machine is giving the value. Because I said I can't identify whether it's 33 or 35. So now, when I look at the red HE, 42. No morphologist in the world can tell you that this is 42. 42 is more than the reference range. It is not possible morphology. So I called her husband and said, her reticulocyte counts are high and all the red cells that are coming out are fantastic. Do you really want to have transfusion? If she's she's not very uncomfortable or breathless, short of breath, just ask her to take bed rest. Don't ask her to come. Anyway, the hemoglobin, every alternate day we are checking her blood. 2 days later, we'll check her blood. So they decided not to come. I didn't sleep for 2 days. I could not sleep for 2 days because, 5.3, I know it's a new anemia and she's, chemotherapy, she's not going to really respond very well. But 2 days later, hemoglobin was 8.2. So they call me magician now, just because of this red HE. So, as they said, it is not the transfusion for the right reasons. If you can avoid a transfusion, even if there's a right reason, that is great. So coming to the hemostasis management, so iron, the anemia can easily be managed. Iron is great. So please trust iron, because you'll say, oh, there's iron deficiency anemia. How many days will it take for the hemoglobin to come up? It will come up fast. You have to have trust on iron. Now coming to the hemostasis part, there is Mr. S, who had a DU perforation, was in surgical ICU, was shifted to medical ICU because he was developing frank sepsis. The coagulogram was mildly abnormal. Over days, he uses either red cells or FFP basically to undergo a procedure. 14 days later, there was a significant ooze from all puncture sites, which is a scenario that most of the anesthetists and critical care people face. Coagulogram slightly mildly abnormal. He was given 4 FFPs and 8 cryos. There was no change. The oozing continued. So this is something as called as microvascular bleeding. So when somebody calls microvascular bleeding, basically it means they don't know what to do, and blood bank also doesn't know what to do. So we told that there's nothing in the repertoire of the blood bank that can help stop the bleeding. So probably recombinant factor 7A can help. Now, how can I identify that recombinant factor 7A will help? Because it's 1 lakh. One dose is 1 lakh. If I'm going to give 1 lakh dose, will the bleeding stop? Not sure. There's another lady who had a atonic PPH, required 11 units transfused. When she came to the hospital, the fibrinogen was hardly measurable. The hemoglobin was 3.1. The prothrombin time was 32. APTT was 93. The fibrinogen was 43. The hemoglobin was 3.1. And platelet count, fortunately, was 1,20,000. So we rushed in 10 units of cryoprecipitate. But she continued to use in ICU even after hysterectomy. So another 5 units of Paxils were given, but still was mildly coagulopathic. Now here again, the obstetrician said, shall we give recombinant factor 7A? Probably she'll stop bleeding, because her, is slightly abnormal only. The prothrombin time is 17, APTT is 42, fibrinogen is 124, the hemoglobin is 10.5, and platelet count is 35,000. So fresh frozen plasma is basically to help patients who bleed, who have a deficiency. It's not any glue or anything like that. It will not help stop bleeding if there is no abnormality. Now to find out that abnormality, the only way is to do the test. prothrombin time, APTT, and platelet count. PTN abnormality will identify deficiency, but after that, you must make sure that there could be a past history of bleeding. So history sometimes is very useful. A short history. Somebody who is a severe bleeder will give a bad field. So that person can easily be identified by just asking, do you have history of bleeding? And they will have history of bleeding. But those who are mild bleeders may ooze a little bit, but surgical people are not much fussed about that field. So mild bleeders, okay, if you identify, it's well and good. But if you not identify, I'll tell you, no surgeon will complain of extra bleeding because the field will still be clear. Maybe an extra mop may be required, that's all. Otherwise, generally, they don't have any problem. But some people can continue to bleed even if they have normal hemostatic capability, mainly because there can be other conditions, especially patients in critical care. Acidosis does not allow hemostasis to happen properly. Hypocalcemia can happen mainly because of a lot of citrate. Transfusion of blood and blood products has a lot of citrate. A low hematocrit can cause problem. I think Dr. Uthvi will be addressing that. And hypothermia. And hypothermia especially has to be kept very much in mind because you must realize that all the tests that are done in the lab are done at normal temperature, 37 degrees centigrade. And when we do and we get the result, we are actually overestimating the hemostatic capability of that person. If the ICU tells that this person's temperature is 35, I may probably reduce the temperature in the machine to 35 and do the test, and I can probably reflect the true hemostatic state of that particular individual. But that's not possible because you can't keep on changing the temperature of the machine. You can do it in Thromboelastogram, but you can't do it in machines. So what's the transfusion trigger for FFP? All the transfusion committees know that because most of the guidelines would have been taken from anesthesia guidelines or from hematology people. Usually they say prothrombin time, abnormal prothrombin time more than 5 seconds and upper range of normal, or APTT also more than 5 seconds and the upper range of normal. But more than the fact that if you get an abnormal PT and APTT, you need to do a very important test called mixing studies. All hospitals that take care of patients who bleed and are going to transfuse blood and blood products have to do this test called mixing studies. That is, mixing the patient who gave abnormal PT or APTT with normal plasma. So it basically means when you have a factor deficiency, when you mix it with normal plasma, the factor deficiency is overcome, and when you repeat the test, you will get normal result. That means there is a factor deficiency, and patient will definitely benefit from giving normal FFP. But if there is no correction, patient may be having an inhibitor. Even if you give FFP, you give blood products, it's not going to stop bleeding. So it's very important to do this test because sometimes patient may be on excess heparin. Even in fact, individuals can have heparinoids. Long surgeries, the heparinoids can increase, and if you give protamine, the bleeding will stop. So this test is very important to decide whether you need to transfuse or not. So mixing and correction studies has got direct implication to therapy. Now, benefits of FFP. Clinical efficacy of FFP is largely unproven. Nevertheless, most guidelines recommend the use of FFP either in massive bleeding or in significant bleeding complicated by coagulopathy. It is recommended to early treatment with thawed fresh frozen plasma in patients with massive bleeding rather than delay it. Further doses will depend on coagulation monitoring, especially doing the PT and APTT and specific tests. Please understand that a quality bag of FFP will raise the coagulation factors only by 8% and fibrinogen by 13 milligrams per ml. So you can imagine how much we need to transfuse to get to normal levels. Cryoprecipitate, of course, we know contains factor 8, von Willebrand's factor, factor 13 and fibrinogen. So only deficiencies of this, if identified or documented, then only we use cryoprecipitate. So transfusion trigger for cryoprecipitate, again deficiency of either factor 8, von Willebrand's factor, factor 13 or fibrinogen. Platelet concentrates are also available for helping patients who bleed, especially those who have thrombocytopenia. So transfusion trigger is predominantly goes by counts, but also make sure that patient is afebrile so that you can decide on whether you need to increase the platelet count because they are febrile. When a patient goes for a procedure, ideally you keep it at 50,000 or above. Certain surgeries like neurosurgery, ophthalmic surgery, you keep it more than 80,000. Some people prefer it to 1 lakh. And if you're going to give spinal anesthesia, 80,000. But you should also make sure that the patient is not on any antiplatelet agents. So when you have a bleeder, what do? Red cells. That is the first, whatever is possible is red cells. Because if you want FFP, you would need to know whether FFP is going to cause harm or benefit. Why red cells? Because it's always available and in plenty. Disadvantage is, stored red cells, so there could be a chance of dilutional coagulopathy. So you need to make sure that dilutional coagulopathy doesn't set in. So please remember, don't replace the volume that you see in the drain, because the hematocrit of the red fluid in the drain may actually be much lower than the back cells that you're transfusing. So don't get driven by, you see something in the drain is red. If you do the hematocrit of that drain, the hematocrit is going to be not even 1/10 of the hematocrit of the pack cell that you're going to transfuse. So you can use hemoglobin or hematocrit as a guide in bleeders, as and when samples can be sent to the lab for testing. Don't panic. You can get hold of now that transfusion medicine has become a specialty, get hold of a transfusion medicine specialist or a hematologist to sort this issue up. Now, most important thing is keep on sending samples for appropriate testing, because it will help overcome the risk of dilutional coagulopathy. And it also documents deficiency of hemostatic factors. So all you require is one citrate tube and one EDTA tube. Now, why is the repeat testing important? Because it will tell you the efficacy of the product that you have given, and also to plan for further treatment, how much more plasma to be given, how much more cryo to be given. So make sure that by the time the surgery is over, keep the hemoglobin between 7 and 9. Now, this is a very common scenario. The anesthetist or the surgeon will say, I can't send blood, the veins are collapsed. So that's a very common scenario. Like, Dr. Erika Wood said that there is always a competition, and sometimes they say, send me FFP, I can't send you citrate blood. Okay, so what if they are not going to send sample? Continue with red cells, but please warn them that there could be a risk of dilutional coagulopathy. So other thing is, sometimes transfusion protocols in hospitals are very useful. Generally, the transfusion protocol is created by a transfusion committee, which will have heads of anesthesia, from critical care, from surgery, from hematology, transfusion medicine. Of course, will be the secretary of the transfusion committee. The medical superintendent will be the chair. Algorithms can be created, and sometimes training can also be generated from transfusion protocol. For example, this study that was done by Somrai, it analyzed 1,449 medical record audits of red blood cell transfusion, 6 months before and then after 6 months from an education intervention. So transfusion not in compliance with the criteria declined from 0.4 to 0.24 among study surgeons, which was almost 40%, and increase from 0.4 to 0.44 among control surgeons. So obviously, educational intervention is quite useful. And these are some of the algorithms that you can create. But there are whatever is comfortable for the hospital, whatever is available in the hospital, that should be used for creating the algorithm. Guidelines can be available from national guidelines, hospital transfusion committee, but there is certain limitation in enforcing guidelines, because appropriate tests may not be available. They may not be reliable. Of course, if you go for NABL accreditation, most likely your lab is going to give reliable results. And the turnaround time, because patient's bleeding, you're transfusing something, then you're sending the sample. By the time the results come, the scenario inside the patient would have changed. The test will not reflect what is happening in the patient at that particular time. That is when a conversation has to be stuck between the lab as well as the anesthetist, because anesthetist will be able to update you on the changes at that particular moment. Hemoglobin and hematocrit as well as platelet counts are available in most of the hospital, but only thing is, can we do something for hemostasis? Sometimes it's good to have a point of care device like thromboelastogram. So thromboelastogram is basically a device which basically you put blood in a cup, and this cup is moving at a short rotation like this. On almost 4 to 5 degrees it is rotating. Now into the cup you insert a pin, and this pin is connected by a torque wire to a detecting device. So when the blood is added and you activate the blood is in fluid state, so nothing will happen to the pin. Moment the blood will start clotting, the wall of the cap will attach to the pin through the clotted blood, and the pin will start moving. And when the pin starts moving, you can see that, this is when the blood is not clotted, and then suddenly the pin will start attaching to the cup and it will move like this, and this whole thing will get traced, and this is a particular type of diagram that will come out. Now there are parts to this. The first part is called the R time or the clotting time. That is the green part. That is when the blood has not yet clotted, and moment it clots, it stops the clotting that, and that's called the clotting time or the R time. Then the pink part is called the clot formation time. That is where the clotting factors, the platelets and fibrinogen are playing together to create the clot. So that's a clot formation time, which basically talks about the thrombin generation. Then there is another parameter which is called as the MCF or maximum amplitude, which is basically the place where this is the place where the maximum clot firmness is happening. Now maximum clot firmness is 80% created by platelets and 20% by fibrinogen. So if the MCF is low, that means it could be thrombocytopenia. So this is a normal thromboelastogram. This is a hypocoagulable. You can see that the R time is prolonged, the clot formation time, the pink is also prolonged, and the clot is actually a very weak clot. This is a patient with hypofibrogenemia. You can see the MCF is low. And this is a patient with Glanzmann's thrombasthenia where the platelets are not functioning. So 80% of the clot has collapsed. That's what I said. 80% of MCF is contributed by. And this is a patient with factor 13 deficiency where the clot starts collapsing, not very fast, but very slowly. When it collapses very fast, then patient has got fibrinolysis. This can be seen in liver transplant. And if you see this, you have to tell the patient to give tranexamic acid immediately. If the patient is on continuous infusion of tranexamic acid, ask them to give a bolus. Because if you miss this, there will be no more fibrinogen in the body and you will be actually operating in water. So this is the time when you interfere and give them extra antifibrinolysis. Of course, you can also identify hypercoagulable state. So sometimes to little talk about recombinant factor 7A, it is basically a very high dose, almost 1000 the level of factor 7A that is in that particular vial. Ideally, the indication is hemophilia with inhibitor, Glanzmann's thrombasthenia and factor 7 deficiency. No other indication. Now, of course, they are indicating it for certain other factor deficiencies. Previously it used to come as a vial of 1.2 or 2.4 milligrams. Now it is changed to 1 and 2 milligrams. But one vial, 1 milligram is close to 1 lakh. 5 milligrams is close to 1 lakh. So it should be only be considered when all measures have been exhausted. Nothing else is going to stop bleeding, like the 2 patients that we discussed. So how can you decide that? So you can actually have a protocol. For example, this is the protocol was in the Westmead Hospital that we had. After 6 units of Paxils given to a patient who bleeds, do the test. If the tests are abnormal and the bleeding is continuing, give 6 FFPs, 6 cryos and platelets according to the count. Repeat the test. If the coagulopathy or the abnormal tests are still abnormal and there is clinical bleeding, they have the fortunate thing of using prothrombin complex concentrate and sometimes factor VIII concentrate. You can give that. Repeat the test. If the coagulopathy is reversed and bleeding continues, ask the surgeon to have a second look to see whether it's an anatomical bleeding. There is something open, ligature is open. Or if the coagulopathy still persists and after plasma products and more than 10 units of Paxils have been given, then you give 1 dose of recombinant factor 7A. Of course, we don't have this much luxury. So in CMC, 5 units of Paxils, then go to the blood products, repeat the test. If the tests are still abnormal, you give Paxils. By the time it is 10 units of Paxils, we decide to give recombinant factor 7A. So coming to these patients, Mr. S, we had a thromboelastogram on him. So if you look at his initial thromboelastogram, when his values were normal, before 14 days, this was his thromboelastogram, which looked quite normal. But when he is having microvascular bleeding, you can see that he's become very bad thrombin generation. So if I can make this look like this, how can I do that? That can only be possible if I give recombinant factor 7A. No other blood product can do that. Only recombinant factor 7A can do that. So we gave recombinant factor 7A, the bleeding stopped. Now this is Mr. HKP who had a subtotal colectomy in surgical ICU. persistent collection in the drain. In fact, the color of the blood that is taken for test and what is there in the drain looks same. That means basically he's draining blood from his body. So every time packed cells are given, fresh frozen plasma is given. So we are monitoring coagulation and hemoglobin using blood and blood products, persistently coagulopathic with fibrinogen as 75, risk of dilution coagulopathy. So we have been calling the surgeons, please come and take the patient back to theatre, reopen it and see whether there is something seen. So initially if you look at the thromboelastogram, you can see okay, but then started becoming slowly coagulopathic. You can see that by the time the surgeon said they are busy in theatre, they can't come, we saw this thromboelastogram, the last one. Bleeding is still continuing. So then we took a conscious decision, let's give recombinant factor 7A in case it works. Because if you look at the thromboelastogram, thrombin generation is poor. So we gave recombinant factor 7A. Over the night, he did not use any blood or blood products. Next day morning, the surgeons took him and they found there was an open ligature. That was closed. So one thing is that recombinant factor 7A will not close an open ligature. Only thing is it will probably reduce the amount of blood and blood products that may be required. So that is one lesson I learned from recombinant factor 7A. Now coming back to the lady who had the postpartum hemorrhage. So you can see that her thromboelastogram was normal throughout the entire process. She only had only little bit of thrombocytopenia and maybe fibrinogen was 124. Can I address that? Because the obstetrician is saying, give recombinant factor 7A, give recombinant factor 7A. And the patient, if he is not able to pay, the hospital has to pay for recombinant factor 7A. So we did not give recombinant factor 7A because the thromboelastogram was looking fantastic. We just gave 3 PRCs and 3 cryos and patient stopped bleeding. So sometimes these point of care devices can help you decide what to give and what not to give. So conclusions are, transfusion can be life-saving but will never be totally safe and should be used only when it's truly necessary. Studies should focus on clinical significant outcomes with the help of strict transfusion protocol. So these are all the things that Erica Woods has already addressed to, so I'm not going to go into that. But please, a famous Chinese saying, the best time to plant a tree was 20 years back, the second best time is now. Thank you very much.